This is She's on Call, a weekly show hosted by ENT specialist Dr. Sajana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Sajana Chandrasekhar. I'm an ear, nose, and throat surgeon practicing in New York and New Jersey.
And I'm Marina Kurian. I'm a general surgeon that does a lot of minimally invasive surgery and weight loss surgery in New York City.
We're very happy to welcome our guests today for our show, She's on Call. They are Dr. Tamara Lewis, MD, PhD, who is a neonatology and clinical trial specialist at Children's Mercy in Kansas City and the University of Missouri Kansas City School of Medicine, and Dr. Miranda von Tilburg, PhD, who is a medical psychologist specializing in children's intestinal health and the brain-body interactions around that at the University of North Carolina, Campbell University, and the University of Washington.
Yeah, so we have a great show today. We're excited. And we're going to first run down some of the news. So if you want to get started with that, Saju?
Yep. And remember, everybody, we're live on all the social media channels. So if you know anybody who's interested in learning from two really smart women we have on the show today, and maybe a little bit from Marina and me, please like and share and tag and have your friends join us. So let's have our COVID update. The World Health Organization reported its highest daily toll of new COVID-19 cases to date, which was 350,766 on Friday. Unfortunately, infections continue to accelerate. And this graph that we have from the European CDC shows the deaths per million people in many countries and continents from January 30th to October 9th of this year. And unfortunately, the macabre leaderboard is Spain, the US, the UK, and Sweden. And at the bottom, with the least deaths per million population, are New Zealand, South Korea, Australia, Norway, and Finland.
Yeah, and I think it's interesting, right? We're still seeing that the virus is very infectious, and but perhaps at some point we're noticing in pockets that maybe there are less deaths actually related to the virus, and we're going to talk about that in a little bit. It's not clear to me why. Many times these viruses do mutate. And I think perhaps that's what's going on, but it doesn't change the fact that people are getting sick. Some people get milder forms of disease. Some people get more severe. And that's something which gives everyone a little bit of pause, even the kids. And I think what we're seeing at colleges and around the country is that they are getting pockets of positivity related to COVID at the schools. I'm keeping close tabs on my kids' schools and seeing what's happening. Because usually the school will reach out to us and let us know, and I haven't gotten any news that everyone has to go home. So it's concerning and interesting to watch.
Yeah, unfortunately, we had several states that on that green, yellow, and red map, there were a few states that had become green, notably in the Northeast, and certain areas that were really doing mask mandates and lots of social distancing. We have either none or maybe one or two green states left. We're seeing this increase in cases. The U.S. on Friday reported more than 57,000 new coronavirus cases, which was its largest single-day tally since August. And then there are some countries where they're overwhelmed again. So, for example, Iran stopped accepting non-emergency admissions to their hospitals because their hospitals are overrun. And Marina, unfortunately, we saw this to an incredible extent in the New York, New Jersey area in April and May, and we're really hoping that this does not happen again. Segueing from that, let's talk a little bit about a super spreader event that became quite famous.
Right. So the White House Rose Garden event to announce the Supreme Court nominee, where they weren't wearing masks reliably. And we have had several people that have become positive, including the president, one of his aides, and of course the First Lady. And Peter James Walker looked at that data and tabulated it, trying to figure out what happened. And you see that even so, if the exposure was on that day, which was September 26th, most of the people started being positive 5 to 10 days after the event. And so
which is kind of what we expect. So there is a pre knowing that you're infective time when you are in fact infective.
Right. So you're asymptomatic, but you've been exposed. And so that's why we're always saying, if you have an exposure, stay home for, 7 days. We've been saying 5. Well, the CDC now says 10 days, right? So stay home for 10 days. I said 7 because our hospitals have, we get tested and they track us, and we have a greater vigilance and surveillance of our symptoms, but it is 10 days. And so they so far have 38 cases that are related to the White House event. But of the 329 contacts for that event, only a third, I believe, have been tested. And of that third, a third of them are positive, which is pretty high, actually. So if you say that people that got tested, 33% of them were positive, that's pretty high. It's a lot higher than what we're seeing in general.
Yeah, we really hope that anyone who feels that they have been in an area where they're less than 6 feet from somebody who may have been infected for longer than 15 minutes, outdoors or indoors, please quarantine yourself, keep an eye on your health, and protect yourself and your family and the people around you from potentially catching the disease. It's an extremely contagious virus. This is not like going to a chickenpox party when we were young and there was no chickenpox vaccine. This is a really bad thing that you don't want to go around spreading to other people. There is a flowchart that we have that we just prepared. We did a screen grab of to highlight the normal course, the typical progress of COVID-19 as we know it now. And you can see that most people recover. Some people get pretty sick and recover, and then some people get pretty sick and don't recover. And please feel free to take a screen grab and kind of really wrap your head around this illness. And again, we are live on all the social media channels. We have incredible guests coming up, and please let your friends know so they can join us. But let's turn to some fun news, Marina.
Fun news.
Yeah, one day you and I are going to get a Nobel Prize. I don't know for what, but we're going to get one.
Oh, we're not. Okay. So let's do this. Everybody, the Nobel Peace Prizes came out, and we have a shot for you guys to look at who won and for what. The World Food Program actually won for peace, which I think is wonderful. And then the Physiology and Medicine Nobel Peace Prize the Nobel Prize went to 3 gentlemen who, for the discovery of the hepatitis C virus, which is so important for many reasons. Like, we never knew what it was, right? Now we know what it is, and now there's treatment for it. And well, first there's diagnosis, then there's treatment. So that's wonderful. And then and vaccination.
Like, we all healthcare workers and most people are vaccinated against this, which is really has saved millions of lives.
Right. And hepatitis B, obviously, also, but this was for hepatitis C. And then for chemistry, it was 2 women, and they created something for the CRISPR gene, which is a really cool thing that, we do if you're doing any kind of gene splicing, things like that. And anyway, they have a really cool shot on that last picture. You saw that they were standing with the double helix. It's, I believe, Suji, was it Watson?
So James Watson, who won the Nobel for the discovery of the DNA double helix, called this the most important biological advance since then. And I think they totally win for coolest picture setup. And because I apparently can't do any show of ours without mentioning my hero, Marie Curie. Marie Curie was the first woman to win the Nobel Prize for Chemistry in 1911, and Drs. Charpentier and Doudna are the sixth and seventh woman to do so. And then physics went to three scientists for their work understanding the universe, including their work on black holes. And of the three, Dr. Ghez is the fourth woman to win the Nobel in physics, the first being, of course, Madame Curie.
Aha.
And we included literature just because the American Pulitzer Prize winner Louise Glück won, and she actually writes beautiful poems of the challenges of family life, of growing older, and mortality and grief. And given all that the world has been through since January with the COVID pandemic, between this and the World Food Program getting it for the pandemic-related food crisis, I think almost all of the prizes this year have some bearing on the thing that the world has been suffering through.
We are now going to introduce our guests after that. So we are excited to introduce Dr. Tamara Lewis. Again, she's an MD PhD who's a neonatology and clinical trial specialist at Children's Mercy in Kansas City, and Dr. Miranda von Tilburg, who's a medical psychologist, again, specializing in children's intestinal health and the brain-body interaction, and she's at the University of North Carolina. So welcome. Thank you so much for joining us. We're excited to have you both. All right, there you are.
Great to be here.
You know, it's funny. It crossed my mind. I wanted to be a pediatric surgeon years ago, and I interviewed Mercy. So it was just like, oh, all right, that's so cool that you're there. I remember going there, and anyway, it's a very great hospital, and just a little bit of, I love to talk about myself, so put that out there. That's what's going on. And then, of course, Miranda, thank you so much for joining us too. And for yours, I was like that gut brain. We call it, you know, there's so much gut brain interaction, right? Of course, there's going to be some stuff with kids and the brain as well. So very exciting and wonderful to have you join us.
Thank you for having us.
We're very glad to have you. Remember, everybody, these are two brilliant women, and you can ask them just about anything. So please send in your comments and your questions and let your friends know who might be interested in this topic. Let's start with you, Tamara. Let's talk a little bit about your work. So a normal pregnancy lasts 39 to 40 weeks, and you're a pediatrician with a focus on neonatology and the tiniest and sickest babies, the babies just around the time of their birth. And I know that there have been incredible strides made in your field over the past few decades. Can you tell us what's the youngest age, gestational age babies that you're taking care of? What are you looking for? What should the parents know that the neonatologist is looking for when they're taking care of their babies?
Well, thank you so much for having me today. You're correct. I'm a special type of pediatrician called a neonatologist that really specializes in very sick newborns. And the field of neonatology is one of the newest fields of medicine, one of the most recently really developed. And over the past couple of decades, we have made incredible strides in being able to care for the most premature babies, and not only being able to care for them in a better way, but making sure they have much better outcomes. So even a few decades ago, a baby born at 28 weeks or 30 weeks gestation would have really struggled. But now we can routinely take care of infants as young as 24 weeks, and they have good outcomes. Rarely, babies are born even earlier than that, 23 weeks, and at the very limit of viability, 22 weeks. Those babies definitely are more sick, are in the NICU longer, but even now, some of them can have really great outcomes. So it's a great profession for any little girl watching who wants to be a doctor one day and loves babies like I did when I was a girl. Consider neonatology.
And it is International Day of the Girls. So here's to all the girls who are going to grow up to be strong women like you're seeing on the screen. Miranda, you've got a lot of clinical and research experience with children who have eating disorders or eating issues, gut issues. Can you talk to us about what is functional abdominal pain and what advice you give parents about this?
Sure. So functional abdominal pain in children is really when children have chronic, recurring abdominal pain, and we really cannot pinpoint what the cause of it is. So they don't have an infection, they don't have anything really wrong with their guts, they seem to be completely healthy. That doesn't mean something is not going on. Lots of times these children, for example, have very sensitive nerves in their guts. So I always tell parents, it's very similar to eating a Thanksgiving meal every day, right? We feel uncomfortable when you eat a Thanksgiving meal, and that's how your child feels after a normal meal. So there's lots that we can help parents with when their children have abdominal pain, sort of letting them know how to approach their children, what to do with their children. And when you think about pain, think about when a child falls down and breaks their leg, for example, or maybe even, twist their ankle. It's good to stay off of that, right? Pain tells us something like, hey, don't touch the hot stove. That's hot. Stop touching it. But when we have developed sort of this chronic pain that's there over and over, it's almost like a car alarm that keeps on going off because there's a little fly around the car. It's not because there's a burglar there. And so it's usually better to sort of ignore it. And that's a really, really hard thing for parents to understand. There's this one study, and you can probably pop up that slide, where Lynn Walker and her team did a study with parents of children who had functional abdominal pain and asked them either to attend to the pain by asking questions like, hey, how much pain are you in? Oh, come here. I'm so sorry that you're in so much pain. Let me hug you. All of these things that parents usually want to do, right? You want to show empathy and sympathy when your child is in pain, and that means you're being a good parent. And then she asked parents, well, what about acknowledging the pain, but then distracting the children from the pain? So instead of saying, hey, how are you? Come here, I'll give you a hug. Just say like, yeah, oh yeah, you have abdominal pain. Let's talk about your dad's birthday tomorrow. What should we make for dinner? Or, how many candles should be on the birthday cake? So distracting them immediately. And as can be seen from this graph, if we distract children, their pain gets better sooner and easier. And afterwards, when in this experiment, afterwards when they interviewed the children and the parents, both of them acknowledged that that's actually a good thing to do. But the parents said it's a really hard thing to do because they still feel that they want to show empathy and sympathy for their child. So we actually did a study where we just enrolled parents and gave them a management training of what to do when your child's in pain. I don't know how many of you have pain, but I have children who used to play soccer, and so they would be on the soccer field, and invariably, they got hurt and they fell down, and the first reaction of all the parents is to just run on the field and take care of the children. And actually, when we do that, we don't teach children how to deal with common everyday pain, right? They need to learn how to cope. So we did this study where we taught parents how to manage their children's abdominal pain. And when we focused on parents focusing on their wellness behavior, so what are children doing well? Hey, you went to school even though you had abdominal pain. Hey, you did this, despite your pain. Versus when they gave a lot of attention, let's stay home, let's watch TV, you don't have to do your homework, etc. Very normal behaviors. We can see that the disability decreased when parents focused on their wellness behaviors versus their pain, and their quality of life increased. So parents can make a really big impact on their children's pain if we, as clinicians, guide them in how to do this. They're with these children all the time. We just see them once in a while. So these are skills we can all teach parents.
It's amazing. But I'll tell you, I have ignored my children's pain. I've been like, okay, you have pain. I'm sorry, but let's go I've done this. I feel like this is going to come back in their therapy years later. And they'll be like, my mother ignored my pain. And then, literally, I took them to the orthopedist. I think we talked about this last week. I took them to the orthopedist because they were both complaining. Turns out they both had something, not something terrible, right? And they were like, you've been ignoring us for years about my knee pain. And the other one was running. And I'm like, it's just a shin splint. You're okay, you know, or like a bone boot, whatever. Therapy. They'll be like, my mother, as a doctor, I didn't want to, I generally call other doctors to help my kids. I try not to diagnose them. And, you know, they'd be like, I need I need an antibiotic. I'm like, no, you're going to the doctor. Like, I won't take care of my children like that. I believe they should be seeing someone other than their mother. Mm-hmm. Plus, I'm not a pediatrician, right? So I have a specialty, but believe me, the looks they gave me, they were so mad. And they were like accusatory looks. I did feel bad for a second. I was like, okay, so I don't know. I mean, I'm wondering if it is great in the moment, Miranda, but what's going to happen years later? You're the psychologist. You tell me.
It's actually very common to switch in between doing too much, doing too little. I'm not saying never to pay attention to your child's pain. Obviously, if there is,
you have to.
That's there for a long time, you need to have it checked out. If they're in such excruciating pain, they can't stand up anymore, you need to attend to it. So there will always have to be a balance. But overall, we really help children who have these chronic pain problems, and other children as well, when we give them the opportunity to learn how to cope with it themselves. And it's a really hard thing. You're not the first parent to tell me this. And that's why we do usually spend a little bit longer with parents than just the 3, 4, 5 minutes we have right now. But it is a balance, and every parent goes back and forth between those two, paying attention and distracting your child.
Can you just describe cognitive behavioral therapy? Because on the slide it said CBT, which is what is entailed? Because obviously it is much more than just 3-minute, cognitive.
Yes. So when we do cognitive behavioral therapy, we focus on both your cognitions and then we focus on your behaviors. And it's really hard, as you just told me, it's really hard for me to change these behaviors around my child's pain because I'm afraid I'm doing it wrong. So we first have to go to your pain beliefs and say, what are your pain beliefs? What are your cognitions around pain? And then let's make sure that those are the right cognitions, right? They're not cognitions that are keeping you behind, that are keeping you from changing your behavior. So we change those first and then we change behaviors. They come next. So that's what we do with cognitive behavioral therapy. And in this case, we did cognitive behavioral therapy with the parents. It doesn't mean that the parents are the cause of the pain. It doesn't mean the parents need treatment. It's just a really great tool for us to educate parents, right? It's used in an educational way, not in a therapy way.
Yeah, that's great. Thank you. I think that provides a lot of clarity around it. Tamara, we want to switch gears to you. And also, if you guys are watching and you want to join our conversation or share the conversation, you can do that. We are on YouTube and Twitter and Facebook, and you can share and tag your friends who might be interested in the conversation as well. And
Marina, we are actually closed captioned on YouTube. So if you want a little help understanding what we're saying, you can read along if you're watching us on YouTube.
There you go. So we want to talk about, switch gears a little bit and talk about a syndrome that you likely see, neonatal abstinence syndrome. Can you talk about that and describe it, and who are we going to see this in? And also, anyway, we're going to talk about opioids, I'm sure. And, that there's been actually an increase in opioid overdoses and use during the pandemic, which is unfortunate. But Tamara, take it away.
Tamara, you're muted.
Okay. Yeah.
Can you hear me now? Great. So many people who are watching, physicians and lay people alike, know that there's been a lot about opiate addiction and opiate overdose in the news. And we really have seen a shocking increase in the amount of people who are opiate addicted in the United States. And some of those people are women of childbearing age, and some of those people become pregnant while they are using opiates. And so the infants who are born to opiate-dependent pregnant women are at risk for having withdrawal when they're born. And that withdrawal is called neonatal abstinence syndrome. And the reason that the newborns have opiate withdrawal is because while the mom's pregnant the opiate crosses the placenta and the fetus is exposed to the opiate, and the brain function actually changes as a fetus so that the brain becomes reliant on that opiate signal. And then when the newborn is born, the umbilical cord is cut, and very abruptly, the infant no longer has that opiate exposure. And so when the baby is born, they have opiate withdrawal. And this manifests in many different physical symptoms that are shown on this slide here. And we have tools to actually measure and score the severity of neonatal abstinence symptoms. And when a baby has very severe opiate withdrawal after birth, oftentimes they come to the nursery or come to the NICU, and we treat them with opiates in order to calm down their symptoms and help them adapt. And slowly, over days to weeks, we wean the opiate medicine away and the infants recover to normal function. So it's a very serious disease that we're seeing with increased frequency. But the good news is that we're learning more and more about the optimal care of these babies through research. I have a research study looking at babies with NAS. And so over time, their care will improve.
You know, I was talking to my cousin, who's a pediatric cardiologist, and she noted that sometimes these NAS babies, the babies born addicted to a substance, whether it's an opiate or barbiturate, they tend to withdraw, like they're emotionally as well as otherwise different in the NICU. Are you seeing that? Like, what are you seeing as you go to that bedside?
So that's a great question. And I think, we don't think a lot about newborn neurologic function. You know, they eat, they sleep, they poop. That's about all we expect them to do. But infants who have substance withdrawal, because their bodies have become dependent to a medicine in utero, they have very abnormal neurologic function. So they cannot calm themselves. They cannot, make calm eye contact with their mother. When you come to the bedside to examine them, a typical baby may get a little fussy, cry a little bit. These babies go berserk if you touch them or examine them. And so they really have abnormal function of their neurologic system, and they really do have trouble with basic newborn functions such as bonding, eating, calming themselves, sleeping. And so the babies who are the most severely affected are the ones where we have to use medicine to treat their NAS. And so what your cardiologist friend observed is very true.
It's, you always imagine it's such a shock to the system, right? Even when you watch deliveries and the baby comes out and it cries, and then on top of it, to get the opioid taken away too and go into withdrawal. That's just it's a horror. And it's unfortunate that it's happening in the first place, but you can see how dramatic that change would be. And then kudos to all you guys taking care of. Neonatologists are tough, but nothing is more tough than a NICU nurse. Okay, your nurse there, they're like, "Who's coming?" We would have called to go evaluate a baby when I was a resident, and they'd be like, "What are you doing here?" And then they watch you. They're really tough. And it's awesome because they're just there for the kids, and it can be so. It truly, a lot of medicine is a labor of love in every aspect of patient care, from the doctors to the nurses to the people, the PATs, but the NICU nurses, it really is, because it can be so hard, especially if you have kids yourself. The toll on someone can be so hard. But
I would love to put a quick plug in for improved treatment of pregnant women. So one of the things we observe in this country is that pregnant women who are opiate dependent, that could be heroin, it can be oxycodone, hydrocodone, they really have trouble finding opiate maintenance programs like methadone maintenance programs or buprenorphine maintenance programs that will care for pregnant women. So honestly, in the United States, instead of focusing on the newborns once they're already affected, it would be really important if we shift our focus to treating these pregnant women more optimally, allowing them improved access to care, and then their newborns could have better outcomes.
that's a wonderful point. I mean, it's always, chicken and the egg, and you really want to get it at the beginning, and do preventative care if you can, or decrease the amount of opioids, or have some kind of control in that situation. Absolutely. Miranda, let's switch some gears and get back to you here. You've done a lot of work on a topic that I didn't think that was so common, on parental attitudes and outcomes in kids with fecal incontinence. I mean, we've all heard bedwetting, and perhaps some of us have had that experience growing up, but fecal incontinence is another situation. Can you talk a little bit about that, Miranda?
Absolutely. So constipation is a really common problem in children, and I think many parents have experience with that. And in constipation, pediatric constipation, what happens is that about more than 80% of the cases, it's because the child is holding their bowel movements. So think about a small child, they're going through potty training, they might have held it too long at some point, or maybe they ate something, and at some point it got really hard and maybe big. And so they try to have a bowel movement. It's very painful. So the child, of course, is going to think, well, I'm never going to do that again. That's it. So they'll hold. And then when they hold, and next time they have to go, it's even more painful. So they hold more. And so pretty quickly, the child is in a vicious cycle. What happens then is that this hard poop that's sort of sitting there in their bowels, poop that hasn't quite formed yet, stool seeps around and then seeps out, and that gets into their underwear. The child can do nothing about that. That just happens. But what happens a lot is that parents don't really recognize that that's what's going on. They think that the child willfully is pooping into their pants. And so they think that maybe the child doesn't want to stop playing, doesn't, like going to the bathroom, doesn't really care about being clean. And so the parents often blame and punish the children for their fecal incontinence when they're pooping in their pants. And really, honestly, the child can do nothing about it until we treat the constipation. And the slide that just was up, we did a study showing that if you take a child to in this case, we're pediatric gastroenterologists, if you take them to there prior to the visit, which is the darkest sort of bar on here, they have a lot of blame and punish. But then afterwards, they actually decrease blaming and punishing their child, and they increase a lot more helping, also worrying about the children, but that's okay. It's another way that just shows that in my work, I do a lot of work showing, looking at parents and how parents can help their children better. And this is just another way that we can, as clinicians, help the parents understand what's going on with the children and why these things are happening, and helping them better, and then solving it in the long run. We need to sort of break that cycle when there's fecal incontinence.
Yeah, so that's a great point about the constipation being the issue. It didn't occur to me. I was like, that's so critical, because there's an underlying cause, and it's not like a psychological cause necessarily.
Well, no, but they are fearful. So, you can't separate the brain from the gut. We all know that when, you're in love, you have butterflies, you have a stressful exam, your stomach doesn't feel well. So we can't separate the two. But yes, it's the constipation driving this, and the fear really of the pain. Or eventually when the child gets a little bit older, it's the fear of the reaction of their environment, including their parents. When the parents get upset about the child pooping in their pants, and the child really doesn't want to go to the bathroom anymore. So sometimes we can contribute to that unintentionally. Again, I'm not trying to blame the parents either. Parents are doing what they think is right and how they should be doing it. And it's up to us to educate the parents. And when we do, the parents really pick this up and go like, oh, hey, this is really important, and I want to help my child. And pretty much all parents want to help their children. So.
We have people watching from all over the world. Thank you so much. People are tuning in from California, from Pennsylvania, from the middle of the United States, from Hastings on Hudson. Sudha Parekh asks, sometimes a kid just doesn't want to go to school or didn't do their homework, or, I remember reading books about how you could draw certain dots on your face and pretend you had some sort of disease and get out of going to school. So how do you're a psychologist and you work alongside with physicians and nurses. How do you help parents understand what's real, what's not real, what they should be paying attention to. How do you help physicians and nurses counsel parents when somebody like you is not there to help us bridge that emotional divide?
Sure. So I think the first one you asked me, like, how would the parent know if it's real? Well, often we don't, but I would always tell parents, err on the side of it being real. It's actually fairly uncommon for children to fake symptoms or fake being sick over and over and over again. So, it might happen once in a while. I think we all have examples of that, maybe even from when we were little. But usually that just happens once in a while. It's not something that happens every week, every month, over a long period of time. In addition, so err on the side of believing your child. In addition, if you do find out your child is faking to get out of something, get to the root of why. It's actually, usually children are quite worried about something when they don't want to go to school. It's not just say like, well, I don't want to go to school. Most children, when they try to get out from going to school, it's because something's going on and they're worried about it. And it might be something small in our adult minds, but it could be really, really big in their minds. So that's number one. I think number two for clinicians is, to think about how do parents experience this? What is going on with the parents? So let me give me an example. I did interviews with parents who had kids with functional abdominal pain. We don't know the exact cause of it. They're often being told, oh, it must be in your head. Well, if it's in your child's head, they would have a headache, right? So it's not all in the child's head. And these children would undergo testing, medical testing. And I would ask the parents, what is the best outcome? What's the worst outcome? Clinicians, doctors' best outcome is to find nothing's wrong with the child and they're perfectly healthy, right? The worst outcome is to find the child's really sick. For parents, it was almost the other way around. Their worst outcome was finding out that nothing was wrong with the child, because to them that meant they still did not know what was wrong with their children. They still were at a loss and worried about what has the doctor missed. And so to understand how parents think as a clinician is really important, because once you know that these are the worries that they have and these are the things that they're after, your communication with them becomes better. So giving a positive diagnosis, saying based on all of these symptoms and what tests that we've run, I am absolutely positive your child has functional abdominal pain. This is how we're going to treat it. This is what is going to be needed, et cetera, et cetera. That helps a lot versus saying, well, your child is healthy, go home. So sometimes any clinician, even if there's no psychologist there, has to do a little bit of, addressing people's worries and anxiety. And I think most pediatricians are very comfortable with that. They see that in their office all the time.
Yeah, I couldn't agree more. The whole thing about your kids are faking it now, right? If your kid has a fever or a cough, you're going to keep them home, or they're already home because they're doing remote learning. And so that was something different. Like the kids had a cough, I'd be like, you can go to school. They had a fever, I would keep them home. I think as parents, we've all done something like this, right? They don't always go to the pediatrician, but they'll stay home. And I would also be kind of thinking like Sudha Parekh who just said, your kids have a test. I'd be like, you have a chemistry test. You have to email your teacher to make sure you can retake it. But now, the New York Times did a great article on figuring out whether it's an allergy, is it a cold, is it COVID-19? And Tamara, what are your thoughts on how are we going to figure out what to do, especially as winter comes, and winter is coming, everybody, and what are we going to do, with what the kids are going to experience? Tamara. Oh, she's muted again.
Tamara, unmute yourself and you'll be good.
There we go. So it's a great question. And I think, it's an especially hard time to be a parent right now. But one of the most difficult jobs that a parent has is to try to decipher, what is allergies, what is typical cold symptoms, and what is coronavirus in my child. And so I really appreciated the Times writing this article to help give some clarity. What I tell my friends and my patients is that, if your child has seasonal allergies every single fall, and the allergies that they're experiencing right now look just the same, monitor them closely for any changes, but that is not necessarily a reason to run to the pediatrician and get a COVID test. If your child has mild cold symptoms, runny nose, a little bit of cough, belly ache, but they don't have high fevers and they're otherwise functioning fine, 99% chance that's a cold like any other cold, any other fall. And so it's okay to watch that child at home. But really it's the severe symptoms like high fever, severe vomiting or diarrhea, and really something that looks different than your child's previous colds that would really prompt a trip to the pediatrician to get tested. Now, the issue of keeping kids home from school for the children that are doing in-person school, I do think we have to have a different level of cautiousness this year. Really what I'm doing with my 3 kids is if they have any symptom whatsoever, I quarantine them from other children. Because even though I know that chances are their symptoms are not due to coronavirus, in this time we just have to be so extremely careful. And so really, as a parent myself, I'm erring on the side of extreme caution of keeping my kids home until I'm sure that they're getting better and that they're not showing symptoms consistent with coronavirus. But it's a very difficult thing to do, and I think pediatricians know it's a difficult thing to do, and so they're happy to partner with families to help give more guidance.
And I think it's important that if they are able to get testing, it has to be in a way that you can get the results back within a day. So if you're getting tested and you're getting the results 7 or 10 days later, that doesn't help anybody. Neil Parekh had 2 very interesting comments. One, he outed his mother for outing him about the excuses he used for not going to school. He's one of the producers, one of the principals of Digimentors, which produces this show. But Neil did ask, are we seeing fewer cold and common upper respiratory infections because children are in fact at home or wearing masks and less exposed? And I'll tell you from an ENT perspective, we're seeing less acute on chronic sinusitis. We're seeing less acute otitis media, which is ear infections that usually result after you have a cold. So we are seeing that masks in the spring and now masks and maybe more isolation in the fall season. We're seeing less sick child visits for ENT complaints. And I wonder, Tamara and Miranda, if you're seeing a difference in your clinical settings.
I do think it's true that, just having children have better hand hygiene, having children be more conscious about what, kids do gross things like not sharing drinks, not sharing food. I think that does generally decrease the exposure to other non-coronavirus viral illnesses. And so I do suspect, even though I haven't seen the data for this fall since we're kind of early into the cold and flu season, I do suspect there will be generally less severe viral infections because all of the hygiene practices are so amplified.
I think that's probably likely true. I mean, we certainly have seen data on the flu from earlier in the year in other parts of the world, and it's been really flattened. And hopefully, I did get my flu shot, by the way.
Yeah, I did too.
I hadn't, right? Yeah, we all did. I hadn't gotten it yet, so I went to the local CVS Minute Clinic, and I was like, I need the flu shot.
We have a comment from Danette Mojica. Her neighbor's 1.5-year-old only had a runny nose and was COVID positive. I mean, this is a really contagious illness, and if that 1.5-year-old is being cared for by a grandparent or an elderly caregiver or somebody with immunocompromised, that's a real concern. So I think, as Tamara said, vigilance and particular vigilance this year is really warranted. We're going to go forward because there's so much we want to ask these women. They're incredible. And we're really grateful for you for sharing your knowledge. One of your areas of expertise, Tamara, is in pediatric clinical trials. And as you know, none of the treatments or vaccines have yet been tested for COVID-19 have yet been tested in children. So can you tell us sort of what happens when consider doing a clinical trial in a child, and then what physicians think about when they're dosing your child with medication?
So thank you for that question. You know, I'm a pharmacology researcher, and so really I spend more than half of my time designing studies and conducting studies to help us understand how to better use medicines in children. And the thing that's interesting is that almost all the medicines that we use in children were actually developed for adults. And then they're studied in adults, approved in adults, and then we slowly figure out a dose, figure out how we're going to use those medicines in children. But the one thing that a lot of parents don't know is that many of the medicines we use in children are not FDA approved for children. Pediatricians use the medicines to the best of our ability, but oftentimes the actual studies to prove the safety and to prove the efficacy have not been done. And so that's my life's work to improve that situation. Regarding what doctors think about when we give medicines to children, you know, when you give a dose of a medicine, it has to be absorbed into the body, and that's the pharmacokinetics or the PK of a drug. When you give a dose, it's absorbed into the body and it leads to an exposure of the drug inside the body. And then based on the drug target, is the drug target in the brain? Is the drug target in the gut? The pharmacodynamics determine the drug response. And so there are so many variables that determine if an individual child is going to have a toxicity or a benefit from a drug. And these are environmental factors, developmental factors, genetic factors. And so all of these things are what doctors think about when we prescribe medicines to children and when we design clinical trials. And this picture is from a review article that I published recently to really help us understand what are the things we need to think about. For example, when a baby doesn't have a clinical response to a drug in the NICU, you know, if the baby is the one in the green box, they didn't have a good clinical response, but they also had a very low drug exposure. You know, maybe they didn't absorb the drug well. If it's the baby in the green box, then what you may do is give them a higher dose of the drug. But if it's the baby in the red box who didn't have a good clinical response to a drug, but had a very high drug exposure, you don't want to give that baby more of a drug dose because then they would probably just have toxicity. So these are the things that doctors think about when we prescribe medicines. And I really appreciate your calling out that the COVID-19 vaccine trials have started in adult populations, but really very quickly, we need to work those vaccine trials into the pediatric and pregnant women populations, because what I don't want to happen is for them to be left behind and that we don't have the safety and the efficacy data that we need for children and pregnant women when this vaccine comes to market.
Those are excellent points. Thank you so much, Tamara, for sharing all that. We do need to test all populations. So my institution was having a vaccine, so I immediately was trying to sign up, right? But it was an older patient, so I couldn't even. So what's interesting is that many of our universities and academic centers and the drug companies are doing this on different populations, though. So that I think is good. Ultimately, we'll get all that data together. I want to switch gears, Miranda. Let's talk about gut issues. We talked about that gut-brain interaction. It's always there. When are some of the eating behaviors in children not just picky eating, right? When is it an issue? And we're not talking about anorexia or bulimia or things like that, but there are situations where kids fall out of being a picky eater and then actually are in a different situation, a different category.
Yes, absolutely. So picky eating is very normal in children. It's especially sort of the ages of 3 to 6 or so, sometimes a little bit longer. It's a very normal phase, and parents often worry about the child getting enough nutrients, eating healthy enough, etc. But it's a normal phase, and most children do fine, and they weather through it, and they start to become more adventurous with eating. But in some children, we have what we call almost extreme picky eating. And one thing that we see, especially in smaller children, is that they just refuse to eat at all. And again, think about what I was talking about with constipation. If a child has a really hard bowel movement and goes, I'm not doing that again, we're starting to realize that a similar idea might be for eating. So if a child gets stomach upset because, for example, they have reflux with eating, they might think, I am not eating again, and so really refuse to eat. And there was a study done quite a while ago by Paul Hyman, who is a brilliant physician who just passed away, unfortunately. But he figured out that in what we call magically fragile children, who often are on tube feedings, because medically that's needed, it's really hard to get them off of it, even after we sort of medically clear them. And the reason might be, what he found out is that these children have gut issues that were previously unrecognized. So a lot of these children had reflux or they had constipation, and it might be their gut issues and their discomfort in their gut that stops them from eating. So he had 9 out of 14 medically fragile children who had gut abnormality. And when he treats those gut abnormality with medications such as tricyclic antidepressants, which work on our nervous system and make sort of our discomfort get a little bit lower, as well as cyproheptadine, which is an old antihistamine that has as a side effect to increase hunger. If you gave this to these children, they actually did a lot better. And 6 out of the 14 were no longer fully dependent on tube feeding. So more and more now there's a realization that if children refuse to eat, especially younger children, that might be due to gut issues that a child can't say, oh, I feel heartburn, for example. So small children don't distinguish between that kind of pain. There's also a second category that's only more recently recognized, and it's called ARFID. It's avoidant restrictive food disorder. And these children almost are like afraid to eat new foods. So they have this extreme food neophobia. And these children don't want to eat. They fear aversive consequences of eating. A lot of times these children have had aversive consequences of eating, oftentimes related. For example, children with eosinophilic esophagitis, they might feel like their food gets stuck in their esophagus, and so they become aversive to eating. And then they have all these sensory sensitivities, so that their gut is just more sensitive to any inputs, whether that's pain, stretching, things like that. And so there's many of these children that are around as well. And this will not just go away with age. We actually I've worked with Nancy Zucker at Duke University, and she has a database of thousands of adults who still have ARFIDs. And so we're increasingly recognizing these people need help. They need help early. And oftentimes these children start falling off of their weight gain trajectory. So that's a really good sign to know that something is more going on with your child than just picky eating.
So thank you so much. We're getting a lot of comments about how helpful this information is for anyone who's a person, anyone who has a child, anyone who knows a child, anyone who was a child. I think this is really very helpful information. I do have something that really hurt me when I read about it, Tamara, and I'd like to talk to you about it because many times on our show, we talk about healthcare disparities in race and economic circumstance. And there was a huge study of 1.8 million births in Florida over several decades. And it looked at the ethnicity, or it looked at the race of the baby and the race of the doctor taking care of this newborn. And it found that, unfortunately, and it hurts me because we have so many colleagues that I could never believe this happening, that Black babies cared for by white physicians had 3 times as higher chance of dying as Black babies cared for by Black physicians, and white babies cared for by either physician did well. So I wonder if you can address some of the racial disparities in healthcare and what you see, especially as you take care of these really sick children who need a lot of care.
Well, Thank you for that question. And I appreciate having the opportunity to speak about racial health disparities on the show. You know, when this paper came out, it caused a huge splash in the medical field because I think it unearthed everyone's deepest fears. It unearthed the fear of parents that their child may not receive equal care in the newborn period based on their skin color. And I also think it really unearthed the biggest fear of many physicians. This is hard data showing that physician-patient racial concordance in newborns may improve care. And so the corollary of that is that, white physicians may carry very, very deep unconscious bias that manifests in their care of newborn children. And there is decades of high-quality research documenting racial health disparities in the United States. For almost every major medical outcome, heart disease, diabetes, maternal mortality, Black patients fare worse than white patients. And in the United States, people, I think, want to assume that children are somehow protected from these racial disparities, but we know that's not true. Dr. Tiffany Johnson did a study looking at implicit bias against Black children in the emergency room, in the pediatric emergency room. And what they did is they gave pediatricians the implicit bias test to see, do they have a pro-white or a pro-Black bias, or a pro-white and an anti-Black bias. And they found that pediatricians harbor these same deep-seated implicit biases just as against children, just as much as they do against adult patients. And the thing that was fascinating to me about this study is that people attacked it immediately. People wanted to tear apart the methodology. People wanted to come up with all these reasons why this data could not be true. And what I would challenge our listeners and what I would challenge my physician colleagues to do is really ask yourself, why could this be true? You know, all Americans grew up in a soup of racism. And so it can come out in very subtle ways in the physician-patient interaction. And I'll give one simple example because I take care of newborns all the time. You know, there could be a rural hospital and there's two very sick newborns in a small nursery. Both of them need to get antibiotics started. Both of them need to get transferred to a children's hospital, but one has to go first. You know, a deep bias could make a physician make a decision about which one of those babies gets prioritized in care. And this is not anything malicious, but I absolutely believe that this data is true. And I think what it means is that we all have to do a better job addressing racism in medicine and learning how to mitigate our biases.
Couldn't agree more. It is heartbreaking to see. All your points are so wonderfully valid, Tamara, because you do think kids are spared. And, you see all those things about racism is a learned behavior because kids will play with each other and think that they're brothers or sisters, and it's not the skin color that matters. And yet, what we do as healthcare professionals and how we interact with patients has to be, each of us has to have an implicit bias, whether we want it or not. It's going to be there. And it's so important to do work to improve that. And I actually hope that all of our institutions really focus on that in the future to try and get us to do better, because, there's so much room for improvement and we have to do better.
The other thing that will help address this issue is decreasing the racial segregation in the medical workforce. So right now, even though Black and Hispanic people make up about 30 to 40% of the U.S. population, if you look at physicians at academic medical centers, Black and Hispanic faculty make less than 8% of the faculty. And so, although it's a long time until we have racial equity in nursing and physician workforce, the more that we can recruit minoritized children into the medical field, the more chances that minority children will have at some point interacting with a minority physician. And so that also will improve the care of everyone.
Thank you so much for those comments. We want to thank you again, Dr. Tamara Lewis, neonatologist and clinical trial specialist at Children's Mercy in Kansas City at the University of Missouri, Kansas City School of Medicine, Dr. Miranda Van Tilburg, who is a medical psychologist specializing in children's intestinal health. Thank you so much. And she's at the University of North Carolina, Campbell University, and the University of Washington. Thank you guys so much for joining us.
Thank you.
It was a pleasure.
We do have, I want to thank you guys for watching. These are our producers, so we want to thank them because this show cannot be done so well without all of them. And then finally, Sidri, you want to introduce our next week?
Yeah, so next week we're excited to talk about bones and joints and inflammation and more. And our guest next week will be Dr. Nancy Yen Shipley, who's an orthopedic surgeon and the host of the 6% podcast, which refers to the fact that only 6% of orthopedic surgeons are women. And Miss London Robinson, a fourth-year medical student who grew up in rural America, which is also not represented in healthcare as physicians and nurses. And she's interested in rheumatology and an advocate for increased representation. So we're so grateful to our guests this week and looking forward to seeing you all next week.